Hi, everyone, and welcome. We're going to get started with today's session. My name is Jeremy, and I am a representative of EHN Canada. We are a nationwide network of treatment centers for addiction, trauma, and mental health. We have facilities located in British Columbia, Alberta, Ontario, Quebec, and Nova Scotia. We offer high-quality inpatient, outpatient, and online treatment programs. For more information, please visit our website at www.ehncanada.com. Just in terms of housekeeping, everyone is on mute and cameras are off for today's webinar, but please feel free to use the Q&A box located at the bottom of your screen to submit any questions for our speakers today. We will try to get to as many questions as we can at the end of today's session. Today's webinar is being recorded, and we will be sending out a follow-up email sometime mid to late next week that will include the link to today's recording, the slide deck that will be presented, and any other useful resources, as well as your CEU certificate. Colette and myself are located in Toronto. Toronto is located on the traditional territory of several nations, including the Mississauga of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat people. It is covered by Treaty 13 with the Mississauga of the Credit. Dr. Nazarov is located in London, Ontario. London is located on the traditional lands of the Anishinaabe, Haudenosaunee, Lunepiwak, and the Attawaddaran peoples. If you are new to this work and would like to find out whose land you are on or grew up on, check out www.native-land.ca for more information. Many more of you may be physically present elsewhere. I encourage everyone to use the chat function to, where applicable, share whose land you are on. Now, to get to today's session, Introduction and Measurement of Moral Injury. First off, we have Dr. Anthony Nazarov. Dr. Anthony Nazarov is a neuroscientist with a research focus on PTSD, moral injury, and social cognition. He is currently the Associate Scientific Director at the MacDonald Franklin OSI Research Center, an allied scientist at Lawson Health Research Institute, and adjunct professor in the Department of Psychiatry at Western University and Department of Psychiatry and Behavioral Neurosciences at McMaster University. Prior to joining Lawson, he was a defense scientist at the Department of National Defense, Defense Research and Development Canada, investigating psychological resilience and mental health in Canadian Armed Forces personnel. Dr. Nazarov is interested in exploring the interplay between psychological trauma, moral transgressions, and how we make sense of the social world. Specifically, he is interested in understanding how we can better identify, treat, and prevent moral injury and related operational stress injuries. We also have Colette Currin. Colette Currin is a counselor working with those affected by mental health and addiction disorders, whether inpatient, outpatient, in-person, or online, either individually or in groups. Her enthusiasm for the recovery process is centered in her own personal recovery journey over the past 28 years. Colette also serves as the National Director for Military Veterans and First Responders, where the calling to serve others can sometimes injure the self. Please help me welcome Dr. Anthony Nazarov and Colette Currin.
Thank you, Jeremy. And let me just make sure that I'm screen sharing. Always the most difficult part of the presentation. So thank you everyone for joining, and it's really a pleasure to be invited to this webinar. What we're going to try to do is, I have quite a few slides to go through, and then I do want to leave some space for questions and answers. Hopefully answers. I think there are a lot of questions, but in this space, not a lot of answers. So thanks for the introduction, Jeremy. I'll just skip that and skip some of these slides then. I do have to disclose that I do have relationships with commercial interests. So I'm a co-founder of Participate. It's a research participant recruitment and engagement platform used in some of the studies mentioned in this presentation, but no person or organization received any financial remuneration for the use of this platform. And I do provide ad hoc consultations to Human Systems Incorporated. First of all, I'd like to thank everybody at the MacDonald Franklin OSI Research Center. A lot of this work would not have been able to be conducted without everybody's assistance and expertise. And again, thank you to participants, advisory council of our center, collaborators, and our students and trainees. So I want to go through I come from a background of military mental health research, so that's the journey that I'll sort of go through. But again, as we discuss this topic of moral injury, it's not necessarily specific to military populations, and you'll sort of see in some of the discussions that we'll have around measuring moral injury that we're trying to be careful to make sure that it's not specific to military populations, and a lot of individuals can be impacted by this in many different occupations and settings. So we'll discuss the military mental health. What is moral injury? Why is it important? What are the current gaps? Measuring moral injury, the moral injury outcome scale that we've developed, other projects that are underway, and Q&A at the end. So I just wanted to bring up this quote to keep in mind. So the pendulum of the mind oscillates between sense and nonsense, not between right and wrong. And I think it's very important as we discuss moral injury. If you're unaware, the Canadian Armed Forces is quite large. We have almost 100,000 Canadians serving in the Canadian Armed Forces, with 461,240 Canadian veterans. So this is according to the most recent census that was circulated, and this is the first time that we actually have a veteran identifier in our national census. So that's an entire area of research that gets opened up when we have this linkage to the military population through the census. So deployments include Iraq, Haiti, Congo, Egypt, South Sudan. We have many individuals deployed on many different missions, and every year that I have the slide on, we said, like, what can we anticipate next year, right? So very hard to anticipate what happens, especially if you look at the developments over the last year or last few months. So when we're looking at operational stress injuries in the Canadian Armed Forces, we see that there's a small, a substantial minority of individuals who do sort of meet the criteria for mental or alcohol use disorder. So you could see that when we focus specifically at PTSD, from 2002 to 2013, we had this jump in prevalence of PTSD. And that's what sort of got many individuals in the community thinking about what may have been the cause or the mechanism behind this. We also know that about 40% of medically released individuals suffering from an operational stress injury, 30% seek mental health services after deployment. We do see an increased risk of suicides in released CAF personnel versus civilians, especially those who are young. And in the US setting, 70% of active personnel suicides are in those 29 years old or younger. And the point of this is to really highlight that there's something missing in terms of our understanding of PTSD, and that's sort of the transition into what moral injury is. So in the Canadian Armed Forces, we have, based on data from 2013, 13% received an operational stress injury during the Afghanistan service. PTSD was the most common disorder. It was 1 in 4 individuals who were deployed in combat heavy zones received diagnosis of PTSD. So not surprisingly, it's significantly higher compared to the civilian population, and about 20 to 30% of individuals who are CAF combat personnel are likely to receive a lifetime diagnosis of PTSD. So guilt and shame are widely reported in PTSD, and both are linked to suicide and suicidal ideation in military samples. But at the same time, guilt and shame, it's common but complex cognitive and emotional experiences, and they arise when one perceives their behavior to transgress an internal moral standard. So really, when you think about morality or this moral code, it's really just a social mechanism. It doesn't exist in a vacuum, in a social vacuum. So it's social feedback in a way. And what we see when we're looking at guilt and shame in the clinical context, is that guilt or severity of guilt is a better predictor of PTSD symptoms than degree of combat exposure. We also see that lower guilt cognitions are associated with PTSD resilience, and shame symptoms are temporarily tied to PTSD onset. This is specific to looking at delayed onset PTSD, typically, most commonly, due to witnessing atrocities. Combat-related guilt is a better predictor of suicide than PTSD or depression severity, and there's significant biomarker overlap that we're seeing now. So one of the hypotheses that have been sort of put forward over the last 20 years is that for some, guilt and shame could be at the core of their distress. So not the fear-based sort of trauma and symptoms related to that fear, but it's the guilt and the shame. So it's this idea of broken heart versus racing heart. I'll just dive really quickly into this important distinction between shame and guilt. Typically, it's used interchangeably, but actually they're two psychologically very distinct constructs. So one is evaluation of the self, shame, it's evaluation of the self, and guilt is evaluation of behavior. And you sort of can go down this list here in terms of different parameters and how it contrasts between shame and guilt. And you could see that it makes sense that shame is more likely to lead to negative outcomes, and guilt is more likely to lead to, let's say, maybe positive or potentially positive outcomes, like self-forgiveness, approach and amend behaviors, as opposed to shame, where it's inward. This idea that future can't be changed, that it's stable over time, and it's due to personal inadequacies, as opposed to context, as opposed to things can actually change in the future and a reparation is possible. So shame is linked to many mental health outcomes that are listed there. But it's interesting, guilt is only connected with these negative adverse mental health outcomes when it's paired with shame. And when you're looking at the DSM, typically it's the maladaptive guilt that's measured in the DSM, not the adaptive guilt. So that brings us to moral injury. So there's been an explosion of research in the space. If we think about telehealth, that's a new sort of technology, and that's also been picking up speed. But you could see how common it is to actually now look into moral injury and the volume of research that's coming out in the space. At the same time, definition is very much unclear at this point. So we have psychology, philosophy, social work, spirituality, all trying to figure out a solid definition of moral injury. And there are now papers that are dedicated specifically to trying to figure out this definition. So I've done my best to collapse and collate all the definitions that are possible that sort of fall under this domain of moral injury. And what you could do is you could just go through this sequence, and you can just choose any one of the phrases in the brackets. So, for instance, psychological distress in response to the perpetration of, maybe bearing witness to, failure to prevent, learning about, any event that transgresses deeply held personal beliefs, subjective moral standards, one's belief about what's right. And it really depends on which discipline you come from in terms of how you call that psychological distress. It could be a spiritual wound, it could be character wound, undoing of character, interpersonal crisis. And Jonathan Shea, very importantly, identified that betrayal is a huge aspect of moral injury. So this betrayal of justice by a person of authority in a high-stakes situation. So when we're looking at moral injury, one of the questions is, well, what's included in it? Well, how's it manifested? So it's alterations in self-perception, alterations in moral thinking, relational impacts, and I can dive into more details about that at the Q&A. But emotional aftermath, typically, as I mentioned, shame and guilt are common, but other emotions could include anger, anxiety, and anger specifically as it relates to betrayal, right? Self-harm behaviors, self-handicapping behaviors, changes in spirituality, so loss of purpose of life, loss of spiritual or religious beliefs, but also it does overlap with symptoms of PTSD. And similar to PTSD, you could think about moral injury in the same sort of sequence of events where you have the PTSD criterion A, that traumatic exposure that a group of individuals are exposed to, and some individuals who are exposed to that psychologically traumatic event will go on to develop post-traumatic stress disorder. So again, not everybody who's exposed to psychological trauma will end up with a diagnosis of PTSD. So only a few. Same sort of theory applies to moral injury. So instead of that criterion A, it's a potentially morally injurious experience. So not everybody who's exposed to a moral challenge or morally stressful conflicts will experience lasting psychological distress. So this is probably a good time to make a distinction between exposure and expression and outcome, because in moral injury, that's somewhat of a wash and also used interchangeably. But that's one of the issues in the literature and in this field, is that because of that interchangeable use, sometimes we're not sure, are we talking about the event itself, that exposure, or are we talking about adverse negative outcomes? And why is that important? Is because, again, many people could be exposed to something that's morally injurious, but not everybody will experience lasting morally injurious expressions or outcomes because of that exposure. So for the clinicians who are here, I'm sure you all know that currently it's not a mental health diagnosis. So classic, at the same time, classic PTSD symptoms and outcome measures like the PTSD checklist of PCL5, they don't measure all those symptoms commonly associated with moral injury, according to the 2 decades worth of research that has been conducted with individuals who may fall under that bin. And another issue is that potentially morally injurious experiences may not always meet PTSD criterion A, psychological trauma. So again, really creates a complex situation in terms of treating individuals and finding a home in the mythology of diagnoses. So there's really this dichotomy and debate. For some, it's a term that finally describes the essence of their struggle, but from another perspective, it may be a subtype of PTSD. So whether moral injury is a construct independent of PTSD is still under debate, but many signs point to yes. So who can be impacted? I did have some slides about Canadian military, but realistically anybody. And when we look at, this is a really great slide to sort of show the spectrum of severity of exposures and severity of outcomes. So everyone has experienced some sort of moral challenge in their life. Maybe somebody's cut off on the highway. Maybe somebody cuts you off at Tim Hortons. You feel as though there's no justice in this world, but maybe for a split second or two, right? And then you go about your day. So you get that moral frustration that is very temporary. It's common, but the degree of mental, social, and spiritual harm and impairment is very little to none. But as you go down the spectrum, you have these events that are less likely to occur, but at the same time, the emotional aftermath, the social and mental aftermath, is more distressing, and the impairment is more and more severe. So typically, it's divided into moral challenges as the exposure to moral frustrations, moral stressors leading to moral distress, and morally injurious events leading to moral injury. Where moral distress ends and moral injury starts, we don't know. But a lot of work has been trying to get us to that question in terms of caseness, right? So who has moral injury, who doesn't? One of the issues is that a lot of the literature and sort of the community uses moral distress and moral injury interchangeably as well, similar to shame and guilt. So that complicates things. So sometimes you would have a measure that says that it's measuring moral distress, but it could actually be measuring moral injury as well. And at the same time, maybe some individuals are actually using it to describe different parts of the spectrum of continuity on this spectrum of impairment. So then who can be impacted when we're looking at this figure here at the spectrum? Well, the individuals who are more likely to be on the right side of the spectrum. And we could use many different sort of intersections to segment the population, but realistically, it's individuals who need to make difficult moral ethical decisions in high stakes environments. So yes, no wonder it's military personnel, but it's also healthcare workers. It's also first responders. It could be the legal justice system personnel. So nobody's off limits. And when we're talking about betrayal can be done in many different contexts, especially in the positions of power and authority, because we work in those kinds of structures, social structures. So why is it important to look into moral injury? Well, first of all, it's common. I already mentioned that guilt and shame are commonly reported in PTSD, but rarely sort of carefully measured in terms of outcomes. But the exposure is common. Specifically, we're looking into these specific occupations like military personnel, and we see that over 50% of those deployed to the mission of Afghanistan endorsed a potentially morally injurious event. And when we're looking at this military context again, exposure to events that may trigger moral injury are common because typically today's operations go against schematic beliefs about warfare, right? So you have increased urban warfare, unmarked enemies deliberately playing against ethical standards, and individuals who are on the front lines need to take on many different roles. It could be combat and humanitarian aid and stabilization of the community. In terms of those exposures, you could sort of see that in this specific study, we used statistics scanned the data sets, and for instance, seeing ill or injured women and children who you were unable to help, over 40%, ever feeling responsible for the death of Canadian or Allied personnel, over 7%, having difficulty distinguishing between combatants and non-combatants, close to 40%. So I did mention that shame is temporarily tied to PTSD onset, and what we also found in our research is that those who endorse that exposure that I mentioned, let's say those 3 items, they're 1.5 times to almost 3 times more likely to have a past year presence of PTSD. So this is controlling for combat exposure, to location of deployment, to other sort of stressful experiences that may have occurred during deployment, and rank experience, etc. So quite a strong relation there. So moral injury is also challenging to treat, or definitely is a complicating factor, because current, typical, and common PTSD approaches may not be appropriate or effective in certain individuals. We know that there's PTSD treatments that are effective, but they may not be effective for all. And this could be one of the reasons why is diving into this aspect of moral injury and shame and guilt and those outcomes that I'll mention in a few slides. We also notice that there are significant barriers to care. So again, relates to challenges in treatment. We notice that those individuals who are exposed to those types of events are twice as more likely to seek help from civilian healthcare providers, as opposed to going to the default standard military healthcare system. So this is in active personnel. So what can we do about it, and where do we go from here? So, well, what we could do is we could try to figure out treatment for moral injury. We can figure out maybe early intervention. So if we know who's exposed, can we try to do something to support those individuals and provide early intervention? We can also prevent by avoiding exposure. So that is another option with challenges. And prevention. So we can prepare individuals to be able to navigate the challenges that could be ahead of them. So there's some issues with all of this. So for treatment, well, there's no valid method to capture and assess moral injury until now, and that's part of the, I guess the topic title is measurement, right? So we're getting into. I got through the introduction. I want to be discussing measurement now. So to date, there was no valid measure to capture and assess moral injury. But we need to know who to treat and whether the treatment is effective. And that's why we need to measure it effectively. So this moral injury outcome scale is something that I'll dive into in a few slides. We also have ambiguous treatment targets and outcomes. So we need to identify targets and measure those outcomes. So again, looking at measurement. And we do know that there are promising interventions that are already being evaluated. Treatment coverage. So depending on this, the country that you're in, it could require a diagnosis. But how do we provide help to those who need it now? And unlike for PTSD, there's no animal model for moral injury. So when we're thinking about pharmacotherapeutic interventions, it is quite hard to do. So help-seeking avoidance, I think, I mentioned that shame and guilt, they're both really socially withdrawing at first, particularly shame, and confidentiality. There's this, we've demonstrated this in some experimental research, is that there's this belief that you would have career and legal risks if maybe some of those details are described within clinical settings or research settings, if you do have a moral injury above and beyond, let's say, a fear-based type of PTSD trauma. And I can expand on that as well. It's research that was funded by Veterans Affairs Canada. Prevention, well, the prevention is also difficult because we need to link the exposure to the outcome. We're just getting to that point, and not all exposures are the same. So we really need to know how to measure those exposures correctly. We don't know what supports are required necessarily, or at least we didn't know until recently. And can we make things worse? There's been, many cases in public health sort of space where interventions that were intended to be positive actually had negative impacts, detrimental impacts. Another issue is that interval between that exposure and adverse mental health outcomes, like those moral injury exposure outcomes, can be lengthy. So can we identify some prodromal symptoms? A very good point that's brought up is that guilt and shame are necessary human emotions. It's a natural response. So what magnitude and impact is reasonable and for how long? For prevention, well, for some populations, different occupations, this is not an option. For some, it is an option. And a lot of times what complicates the matter is that what isn't perceived to be a potentially morally injurious experience now could be reframed as a potentially morally injurious experience later. So we really need to understand the impact of culture on our understanding and reframing of those experiences. In terms of preparation, there's this long gap between training, exposure, and expression. So that complicates discovery of evidence and empirical evidence to say what's effective and what's not. And what are the goals of preparation? How do we measure outcomes? How do we deliver the intervention effectively? And really, it's not prevention of moral injury. It's really moral ethical decision-making training. So measuring moral injury. So over the last 20 or so years, there's been many scales that have been developed. There's significant challenges with this as well. There's a lot of overlap and duplication across fields. So typically, moral injury is a term that's stemming from the military space. Moral distress is mainly stemming from the healthcare space. And again, as I mentioned, there's some theories that put them on a spectrum. So moral distress is less severe than moral injury, but for certain occupations, it's equivalent. And the terms have just been commonly used within those populations. So that complicates things to understand what measure should I be using for what population. Quality of scale development and psychometric performance is varied and drastically different in terms of quality. So some scales could be very popular, but they don't actually measure what they're supposed to be measuring or intend to measure. And there's this issue with conflating exposure with expression with moral injury. So to give you an example, this is the most common moral injury measure that exists, the moral injury event scale, so the MIOS. 9 items, very simple. Seems like it's really getting at moral injury, at least we thought. But what we could see here is when we start dividing into exposure and expression, we see that there's some questions that are exposure, there's some questions that are expression. So I saw things that were morally wrong, and then I'm troubled by having witnessed others' immoral acts, right? So if you didn't see things that were morally wrong, typically you wouldn't have been answering to question 2 as well. But you could also be seeing things that are morally wrong, but not troubled by them. So that really complicates things when we have to add up these items to a single total score. Sometimes groups use subscales, but the subscales don't distinguish between exposure and expression. They actually distinguish between, let's say, perpetration and betrayal. And you could see question 7, 8, 9. I feel betrayed by leaders who I once trusted. I feel betrayed by fellow service members. I feel betrayed by others outside the U.S. military. This was developed in U.S. So you could see that, well, the betrayal piece, you feel betrayed. It's kind of like an outcome, but it's also kind of like an exposure. You don't really know where to bin that one. And at the same time, it's not, you constantly need to adapt this to different populations that you're using it in. So one, if you go down that bullet list in terms of issues with the scale, it conflates exposure with expression. Expression, that outcome, I'm troubled by having witnessed others' immoral acts. That is not clinically relevant or targetable. We know that they're distressed, but we don't know exactly what that this trouble is expressed in terms of emotions, behavior, etc. It's not linked to a specific experience or event. That's another issue. We can't monitor a change over time using this measure because it's not linked to a time window. Let's say PTSD symptoms on a PCL5 checklist, it's in the past month. There's some versions in the past 2 weeks, etc. But this is just a general scale. Here you go, fill this out. Did you see things that were morally wrong? It's hard to sort of anchor to a window of time here unless you explicitly state it ahead of time. But there are no clear instructions to those who are administering the scale to say, okay, well, is this during a deployment? Are you troubled by it at any time during the last 5 years since you came back from deployment? Or is this like right now? Hard to tell. And what we've done is we've actually used a national data set using Statistics Canada data again, and some clinical data with our group. And we noticed that psychometric performance is very poor with the scale. So that means that it's actually not measuring what it's supposed to measure. And we can't really trust the numbers that are coming out from people's responses here. For the interest of time, I'm going to skip some of these slides and go back to them if necessary. So what we're trying to do now is we are doing a systematic review of all moral injury and moral distress measures that are in existence. And there are about 20 of them. So what we're trying to do is we're assessing alignment with this conceptualization of moral injury and moral distress. We are assessing the domain coverage of those outcomes or symptoms. We are careful to capture exposure versus expression distinction in these scales, or maybe sometimes they're conflated. We are also assessing the quality of scale development processes. and we're assessing the quality of previous psychometric evidence, because we noticed that it's not enough to just go into the psychometric publications to look at the findings and their conclusions, the author's conclusions. We are looking to see if they've conducted their methods properly according to best practices. And what we're aiming to do is provide recommendations to the community regarding which measure is most appropriate for what use. And to that end, I want to discuss the moral injury outcome scale. So this is something, this is a scale that we've been working on for 7 years now, or longer. This is a scale that just was published this summer. And this is an international consortium that was involved in this development, led by Dr. Brett Litz. So we started really from the ground up. We wanted to understand the phenomenology of moral injury. So we started with interviews with clinicians, with patients, individuals with lived experiences across different countries, Canada, US, Australia, UK. We had careful selection of content domains in terms of what are the outcomes that could be altered in this in this syndrome, let's say. And we generated items that are specific to moral injury, not necessarily overlapping with other constructs, let's say PTSD or depression. We conducted best practices item reduction, cross-cultural invariance testing. So that means that the data that is collected in Canada can be compared to data that's collected in US, to UK, Australia, across all the allied nations. So this is a 14-item scale assessing self-reported past month outcomes. So I'll break this down. So 14 items, relatively short. So that's good. It's a self-report. It looks at past month symptoms related to the most disturbing event. So we're anchoring it to an event. Most disturbing event of their life that they're currently distressed by, that was related to a violation of important moral values. And we have 2 subscales in there. We have shame-related outcomes and trust violation-related outcomes. We are also characterizing the type of experience that they've been exposed to. And it's designed for in-person or remote administration as well. And there are different versions for ease of application. And that's what I'll go through right now. So this could be really a busy slide, and I'll just walk you through it really quickly. The point that I'm trying to make here is we say that it's a 14-item scale, but it's 2 pages long. Okay, well, why is it 2 pages long? Because what we're doing is, on the right side, that's page 2, you have the core 14 items. But what we're doing is, we're also collecting a screener. So the first is, well, you have to endorse that there was some sort of very stressful experience where you did something wrong or failed to do that went against your moral code. You saw someone do something or fail to do something that went against your moral code, or you were directly affected by someone doing something or failing to do something that went against your moral code. So being betrayed by somebody you trusted. So if you have had that experience, you go on to do this questionnaire. If you have not had that kind of experience, you don't complete this questionnaire. In research settings, we also administer it to people who say no for sort of like a sanity check. But for sort of practical purposes, there's no need to complete it for those individuals who haven't had that kind of experience in the past. So then we ask, okay, well, for that event specifically, thinking about the worst event that currently bothers you the most, did the event involve something that you did or failed to do? Event that you observed someone failing or acting, or that betrayal, so that's C. And the thing is, you can have them overlapping. So you could be observing somebody and feeling betrayed, maybe by the system or by the leadership. Or maybe you did something, but you did something because you were betrayed by the rules of engagement that you had to follow. We also ask certain questions like, let's say, which year did this event happen? And then what we do is we add the PTSD screener in there. So to get at this idea, well, how is it different from PTSD, specifically to this event in terms of criterion A? Does it meet criterion A, piece and you know, a 5-item screener. We also ask individuals if they feel comfortable to briefly describe the worst event. On the right side, we have the core 14 items. And then additionally, we have a functional scale that says, okay, well, how much has this experience made it hard for you to function in each of these following areas? Now, the reason why there's so much, you know, passenger items associated with the 14 items core scale is, first of all, it's optional. So, you know, the screener is not optional, but everything else after that, it really depends on the context that you're collecting this information in. So let's say if you're conducting a research or let's say clinical settings and you don't want to measure or assess or have individuals describe their worst event. Maybe it's collected somewhere else. Maybe due to ethics, you can't collect that information. That's okay. There are versions of this scale that remove certain aspects of this entire assessment. Same as functional outcomes. Maybe you're already collecting functional outcomes. Maybe you're already collecting a PTSD screener or a PTSD symptom checklist. There are versions of this MIOS instrument that removes those pieces to make administration more appropriate and let's say faster. So here are the items. I won't go into too much detail because I do want to leave some space for Q&A. But I just wanted to show some preliminary findings. So this is a study with Canadian Armed Forces where we did use the scale. These are individuals who were deployed to long-term care facilities during the COVID-19 pandemic as part of Op Laser. So this is long-term care facilities in Ontario and Quebec. And among those who were deployed, close to 1/3 indicated that that deployment had events that were the most disturbing, morally disturbing events of their lives. So, you know, sometimes if we don't measure these things, we totally lose sight of it. So here we knew that there could be some issues related to moral distress and moral injury in this kind of setting where you're taking care of elderly, Canadian elderly, so it's domestic deployment. And we know the data showed that 1/3, for 1/3 of the individuals, this was the most distressing event of their morally distressing event of their life. And what we found here is that, you know, we would assume that these exposures are mutually exclusive. Maybe some individuals were betrayed, maybe some individuals witnessed something, maybe some individuals had some sort of action or inaction by themselves. So the moral agent was them. But what we noticed is that there was more overlap than them being mutually exclusive. So many reported experiences that they had, you know, both betrayal and witnessing of some sort of moral standards. So why is the scale so important? Well, first of all, it's linked to an event for the first time, similar to PTSD, so paralleling PTSD checklists. There's significant effort that went into ensuring gold standard scale development practices and techniques. It adequately measures moral outcomes, so symptoms that could be used as targets in clinical settings, where you can monitor those outcomes as part of measurement-based care. It adequately classifies exposure type separately from those outcome questions. A solid test-retest reliability that has been demonstrated. The scale was intentionally designed to be population agnostic. So it means that it can be applied to any individual. So it doesn't have to be military specific. None of those questions are military specific, unlike most other scales that are very much population specific. And there's a French language version that is available as well. I'll skip a few of these slides. So this one is an interesting one. So we've been conducting for the last almost 2 years now a study on Canadian healthcare workers during the pandemic and assessing their moral distress and moral injury. So this is a 1.5 year long study. So we followed up healthcare workers for 1.5 years, and the MIOS was included as a measure in this survey. And we're just conducting analysis now, so it's preliminary, but we're seeing that moral injury, as assessed by the MIOS, and specifically trust violation related outcomes, so this aspect of betrayal, predicted intention to leave their job. So in this context, in terms of, you know, issues with retention and recruitment, NHR sort of difficulties in the healthcare context. This is a very important finding. And what we found is that adding things like PTSD symptoms, depression symptoms, anxiety symptoms and burnout severity of these healthcare workers added very minimal predictive power above and beyond what can be collected with 14 items on the MIOS, which is amazing and amazing in terms of predictive power and assessing who should be maybe targeted for intervention. And intervention does not always need to be in the clinical sort of spectrum. So more analyses are ongoing, but that's a very exciting finding that we have. So what are some of the other projects and next steps? So the MIOS is now used in longitudinal outcomes to track trajectories over time. So it's embedded in clinical settings, and there's significant uptake of MIOS use across organizations nationally and internationally. We want to understand exposure better. So what are potentially morally injurious experiences? How do we reconcile them with current understanding of criterion A? How do we improve the ways that we measure trauma, psychological trauma exposure? Are individuals with moral injury avoiding care? How do we reduce barriers? And maybe getting to this idea of moral injury caseness. Who needs treatment and when? And really getting at epidemiology. Again, moral injury is just some of the, just one domain of work that we do at our research center. But if anybody's interested in collaborating with us, we are always looking for collaborators. If you're interested in our research, I invite you to explore our website or sciresearch.ca, and you can scan that QR code if you want to submit your information, if you want to collaborate with us or get more info on studies. Thank you very much.
Well, first of all, Anthony, thank you so much for an incredible presentation. I really mean that. Every time I listen to you, I learn more and more about what this is about. And I really appreciate your passion for furthering moral injury and getting it recognized. One of the questions that was raised by somebody was, what do you mean there's no diagnosis for this kind of everyday trauma? You know, the kind of thing that I think we're all becoming increasingly aware of. And I like the way that you had put that is like it's still trying to find its place in the anthology of diagnoses. And I wonder, I don't even know if you want to address that really quickly as to how that might be coming along for it to be recognized as such.
Yeah, absolutely. So if you remember that slide where I was showing them the MIOS sections of the scale, we did have that functional piece, right? So in the end, we want to understand functional impairment. Symptoms is one thing, but if they can't functionally navigate in their daily life, that's an issue, right? So I think that piece is an important link to identifying caseness, because we have evidence to see how PTSD symptoms, what severity of PTSD symptoms align with what levels of functional impairment. We can almost reverse engineer that to say, okay, well, at the equivalent level of functional impairment that somebody with a PTSD diagnosis may have, here is where they may fall on the moral injury outcome severity as well. So that could lead to potential thresholds to say, okay, well, at this point, this individual may be a good potential target for intervention. But it's a long road ahead in terms of modifying DSMs, et cetera. It's we need a lot of evidence behind that to support those changes.
Yeah, and I mean, on that note, as you said, the improvement from the MIOS, that you've done with the moral injury outcome scale, which I'm very excited about, and we certainly want to look at implementing into right across our network, to start gathering this data, as you said, to get that evidence. And I like the improvement that it's made on conflate, sort of getting rid of that conflating exposure versus expression. So I want to talk, before I come to to exposure, because we did have some questions around that as well, is when we look at expression, you had mentioned that it's got what did you have there? You know, moral, social, spiritual impairment that happens. And so, and of course, those were included in your 14-point scale. But I guess my question segues into treatment, and probably because you had to jump over those slides, the answer lies in there. But what should clinicians be thinking about in terms of treatment? And I'm kind of alluding a little to the spiritual aspect as well, because I think that that's something that makes it quite different from how we've measured PTSD to date or treated it.
Yeah, good question. So when we were designing the scale, we looked at those alterations, right? So self-perception, moral thinking, relational impacts, emotional aftermath, self-harm, spirituality. So those 6 domains where we were intentional to make sure that at least one item was measuring alterations in each of those domains. So even though we have shame-based outcomes, trust violation-based outcomes, we ensure that content domain coverage, even when we have such a small number of items, doesn't get lost. So when it relates to treatment, each of those items could potentially be a target for treatment.
Okay.
Absolutely, and then you can monitor that the success of that treatment over time. And when it relates to aspects related to spirituality, emotional aftermath, you know, with moral injury specifically, it's a social bond, social contract that's violated. That social contract could be between, well, it's between you and society. When it relates to shame, there's one sort of outcome or expression of those sort of spiritual and behavioral issues. And then when it's betrayal and that trust violation aspect, we are thinking, and the data is showing that it's a different type of expression, but sort of on the severity across those domains: relational impacts, emotional aftermath, etc., spirituality. So absolutely, a lot of it is a reparation of social contracts and social connections, and so that meaning making that needs to be done, and the almost like getting back to balancing the goodness versus the badness in the world and within me as an individual. Let's say if I've transgressed something. So a lot of the interventions really need to focus on reinstating that trust and that social contract with the community and with others.
Wonderful. I loved how you showed the continuum, you know, of severity, and that sort of how that's important in terms of how it relates to treatment. And you and I have had discussions before about this kind of spiritual aspect in terms of treatment, because it always strikes me as presenting a lot of overlap with some of the wisdom embedded in the 12-step model. You know, that idea of forgiveness of self, forgiveness of others, making of amends, meaning making, you know, what is my sense of purpose, but also in the making of amends, that I get to view myself differently. You know, that yes, this might have occurred, but how do I take it forward from here? So you know, not only in terms of formal treatment, I think, but in terms of sort of these peer support group, social bonds and connections and so on, and the value that they may play in this moving forward. I want to come back to the exposure stuff. Because there were some questions about what happens when, you know, you talked about trying to prevent it, you know, exposure altogether, or, you know, early intervention. What happens when you have exposure on a mass scale, such as the George Floyd, you know, murder, COVID, you know, a pandemic on a mass scale? What about those, and how those are being viewed, measured, treated?
That's a complex question. We're still trying to figure that out. You know, there's on a mass level, in terms of time, first of all, like we do still need some sort of anchor to time, typically. but we do see that, through interviews with individuals with lived experiences for moral injury, a lot of the times it's not that core initial exposure that creates those lasting negative impacts in terms of the social broken bonds, but it's what happens afterwards, right? So let's say hypothetically, there was sexual trauma or assault within a military setting. It's how the organization took care of that afterwards, or did not take care of that afterwards, is what created that aspect of betrayal, more so than the initial sexual assault to begin with, right? So we're battling with that in terms of how do we capture that adequately in these types of scales, but this is part of that research and collection of information during the screening in terms of what was that experience. I think once we get more information, more data on this, we can start to maybe get better ideas in terms of how do we approach different exposures in different ways. Whether it's on a mass scale in terms of time, but here's another example. Our rollout from Afghanistan, right? So leaving Afghanistan, and perhaps this aspect of re-traumatization for Canadian Armed Forces veterans who may have been deployed in the past, and now they're hearing the news that all the allied forces are leaving Afghanistan, and perhaps maybe betraying those individuals who they used to work with, the Afghanis who used to work with the Canadian Armed Forces, with allied forces, right? So it's very complex, and that's what I mean about like the social context around these events really matters. Yeah.
Beautiful. Honestly, you kind of segued into exactly where I was going next, and one of the groups that we're really working closely with at the moment is the RCMP out in Atlantic Canada, and a good example of that too was obviously the very traumatizing Portopiki incident that happened 2 years ago, and sometimes these events they blindside everybody in terms of how do we handle this and deal with it, and yet if there is the perception that I don't know that institutionally we were cared for in the ways we would have wanted to be, that there is a sense of institutional harm, that there was not being adequately cared for. So these issues are complex. I see Jeremy has jumped up to stop you and I talking, because we could go on the whole day long.
I was just gonna give you a one question, like if you want to do one more question, then feel free. But yeah, no, Colette, if you have another question, feel free. And then unfortunately we're gonna have to end because our hour session is here. But like you said, we could listen to you all day, but it's unfortunate we have time for one more.
Sure. And, Jeremy, I know that you've been scanning the questions that have been coming up, and I wonder if there's anything there that people have been asking as we go that we should be addressing.
I think there's a pretty general question. I know we kind of touched upon this a little bit earlier too, but there was just a comment, and I was wondering if Anthony wanted to give his kind of perspective on it. So the comment was, I think we need to be careful in terms of who is included and excluded from these diagnoses. I see military as the target, which is a traditionally white privileged establishment. So others who are subjected to these daily onslaught of violence are totally discounted. If you just want to kind of maybe dissect that.
Yeah, sure, absolutely. The thing is, I come in with the research presented here because that's the research that I've conducted. But there is an entire community of researchers who focus on their own specific populations. It could be first responders, it could be issues related to racism, it could be in issues related to discrimination, etc. So when designing the scale, we intentionally did not want to exclude any individual so that the responses would be appropriate to all without any need to adjust the scale any further. So we can always ensure that everybody would be able to answer those questions, and therefore also have no barriers to treatment because of the, let's say, the intersectionality that they're coming from.
Beautiful. because I had seen as well earlier that somebody had raised the question too. So as you say, I love that you said that these could apply to anyone. There are nuances, like as we dig into data and we look at that in more depth, is perhaps if I am out there fighting against people that are of a different culture, religious, racial background, you know, how does that maybe even layer into the complexity of you know, we see ourselves as a certain set of people and we're perpetrating harm against others, and what does that say and how much does that complicate it? So you can continue to layer all that in, I'm sure. Yeah. Okay. Yeah.
I think that's great. Thank you so much. And as both of you said, like there's so much more research that being conducted within moral injury, and these are just like stepping stones within that type of research that can be taken. So all of these questions are great to bring forward. And then, like you said, stepping stones to next potential topics, next potential research areas, whatever it may be.
Yeah.
That is no time.
And then I guess the only other thing I'll add, you know, Anthony, is a lot of the questions that I had in mind to ask you too. You know, I just think were very well addressed in the presentation. So again, I really can't thank you enough. I can't tell you how much I appreciate it, and I'm sure I speak on behalf of many. But also loving the new scale. Because I do like the way that you're screening for the PTSD, and as you said, in terms of what it exactly is being measured, is how do we look at those different elements of moral injury and which one is kind of raising its head more than others. And you know, I mean, there are a lot of questions, obviously, and I'm sure you have them too, as you indicated, with what do we still need to learn through research, but how do we measure those and continue to fine tune that, and then perhaps just hone in on treatment on one aspect, and then how do we measure you know, just the outcomes with regard to that specifically, and I'm sure we'll just
absolutely. You know, I think the first step is to make sure that we have the right measurement. You know, we could measure moral injury well, and now we're empowered to ensure that we could accurately capture the effect of different treatments to different populations to see, is this working? To what extent? What treatment targets are actually being improved? Yeah.
Wonderful.
Absolutely. Yeah. Thank you so much to both of you, Colette and Dr. Nazarov. Like your insights, your questions, everything was so appreciated and informative. To echo what everyone's saying in the chat, thank you for providing such a insightful and timely topic, and your research is greatly appreciated. So thank you again for taking your time today.
Thank you. It's been a pleasure.
Of course. And to everybody that attended today, thank you so much. As mentioned, we will be sending out a copy of today's webinar recording, the slides that were presented, as well as additional resources sometime mid to late next week. It will also include a copy of your CEU certificate. And that concludes our webinar series for the year 2022. So we will be in touch with everyone in 2023. Until then, happy holidays and take care.